back and look at some of the material we talked about in the very first module to kind of get your mindset into the differences in pediatric dosing and prescribing, things you need to remember. And then we're going to work through a series of problems just in class. I can tell you on your test you will also have those same kind of problems. The things that your upperclassmen have told me is that when they walk onto Peds, they expect you to already know doses. So the ones we're going over and the ones that I've given you the list on are very common ones used in pediatric practice. So you must memorize those. On the test, I will give you information. It may or may not include the dosing, and you will have to figure out a dosage form or a dose per day or the volume that needs to be dispensed. Not dispensed, but that you would write on your prescription. Okay? So what we go over today will reflect somewhat what you're going to see on the test. I'll tell you, last year bombed it. They did not listen to me, they did not take it seriously, and they flunked my section. So I'm just telling you, what I'm telling you is pay attention. Theirs came later in the year, so they were pretty much done, I think, and it didn't translate well. So what have you had so far in Peds? What, did you just have your introduction yesterday? What did y'all talk about?
Just cardio.
Say again?
Pediatric cardiology.
Oh, okay. Okay. All right. Okay, again, if you look on those learning objectives, there's a list there for dosing regimen that you'll be responsible for on the test. There are also, did I do max doses on yours on the very first? Yeah. Okay, so I've got also given you some max doses I want you to know. All right, so I will also refer you back to that handout I gave you in Module 1. I took excerpts from this, so they're very similar in the beginning. So again, children are little adults, and neonates are not small children. They're very different. How are they different? What kinds of things have we talked about that are different between even infants and children? Their metabolism is different. Their renal function is different. Their renal function develops a little bit faster, but the liver can take at least a year before it is fully functional in terms of just things like glucuronidation. We rely on the ability to conjugate a drug to get rid of it. What does conjugation do that makes it easier to get rid of?
Water soluble.
Makes it water soluble. Makes it polarizes it, and the kidneys can get rid of it. So a lot of drugs undergo two steps. The liver does something to it that allows the kidney to get rid of it. Okay? So in kids, they don't have that ability, babies. They develop it over the first year. So dosing for a neonate and dosing for a 6-month-old would be different, or a 9 or 12-month-old. Okay? And for some drugs, their rate of acceleration of metabolism really zooms forward up until puberty. And then it goes back to what adults. So children are really different in terms of hepatic metabolism compared to either end of the spectrum. They're really, really young in the adults. Okay, anything else that are different? There are other things that are different. So what else? Skin absorption is different. What else, Dim?
Isn't there like water ratio or something different?
Yes. So children get much more dehydrated more rapidly because their body surface area is greater than compared to adults. So you've got a lot of skin, you got a little body. In adults, you got a bigger body, bigger water reserve. So they evaporate faster. Their their body weight is different. So when we replace their fluid volume, we do it differently. There's different equations for children versus adults. Anything else? Okay, we'll hit some of the others as we go through them. If you look down at the bottom, just a reminder about dosing guidelines. So with kids, a lot of it comes, and another big difference with adults and children is that we have, with adults, we've got a lot of data. When we talk about evidence-based medicine, there's a lot of it for adults. There is not for children. It is so much harder to get children into clinical studies. You can imagine the hoops that people would have to jump through in order to enroll 2- and 3-year-olds into a study. It just doesn't get done very much. Because then you're relying also on a parent or a guardian, because children can't give consent. So there are some differences there in what we base our understanding on. So in pediatrics, what you'll see a lot of is case reports. So my pediatric counterparts, me and in pediatrics, they publish a lot. They publish what they see. They do small studies just to see what a dosage form does or how kids react or adverse reactions. So very different data coming out of kids than for adults. So that makes it much harder to know exactly what to do. I'll say the pediatric groups are very ingenious though. They do communicate a lot. There are books that are put out just for pediatric formulations, especially with IV. So when I was the assistant director over the pediatric pharmacy at Children's Hospital for about 3 or 4 years back in my young days. And we had pharmacists, pediatric pharmacists are golden. I just don't know peds. I don't practice it. It is a whole different art and a whole different knowledge set. So we had everything in terms of protocols that doubled up everything. So we always checked each other's work. Pharmacists, tech. So lots of calculations, because number one, that's one of the biggest problems in peds is calculation errors in terms of adverse effects and toxicities. So we did a lot of doubling up. We also unit dosed everything down to where the nurses did not have to calculate. So one thing I'd say if you work with kids is never be offended if somebody questions your calculation. They have the patient's back, number one, but they also have your back. So if a pharmacist ever calls you and go, I just want to go back over that calculation, thank God for them because they are saving your butt. The other is also check each other. I would say with peds, always have somebody check your calculations. All right. If you work in an area of peds, get to know your pharmacist, especially if you're in a hospital base. Those pediatric pharmacists are worth their weight in gold in terms of what they know. Okay, so dosing guidelines for kids. So age base is common, but it's not the best. But you'll find a lot of places will say for kids, like when we look at like ibuprofen or Tylenol, it tells you per age range. Okay. So that is good in a way, but it doesn't take into account all the differences in that age group. Okay, so probably for drugs that have a wide margin of safety, it's not going to be a problem. Drugs that have a tighter safety net are going to be more problematic. And for those, for the most part, people use body weight. Okay, so body weight's a little bit better, and when you have it, use it over age. The big problem you get into body weight is that you can exceed the adult dose. So one of the things we do is we don't do that. And we'll see in one of the prescriptions today, the kid's weight puts them way over what the adult dose would be. So here's where you have to know both. And so with your heavier kids, your obese kids, then you could easily exceed the maximum recommended doses for adults. So it gives you some examples there. So you're usually going to have to convert their weight into kilograms. The other problem with kids is that you have to have accurate weights. and you've got then to convert them usually into kilograms. So you all are proficient at that, you've done it a lot, but it is a source of error because you're having to convert something from one unit into another. The other thing with calculations is always to look at it, does it look reasonable? I always do that. I always look at it again. It's like, does that sound like within the realm of reason of what I know about the drug and what my experience is? Okay. So the advantages are listed on the next page. The disadvantages: no established cutoff in the result in the exceeding adult recommendations. Body surface area is probably the most accurate for some drugs. Like chemotherapy always uses body surface area. Even with adults we do that with some of the chemo agents. The problem is that it's not always easy to do. There are calculators online, but I went to the different calculators, I plugged it in, and I got about 10 different answers because there are many different ways to calculate body surface area. So I'd say if you're in a group that does that and it works for them, then I would adopt that one. But I would know that when you go online and if you use a BSA calculator, it may not be give you the same as another one. So it's not going to be used very often. So your best ones are your weight-based. Conversion. So there are times where people convert an adult dose into a pediatric dose, but the biggest thing is look for or consult references that stand the test of time, and I've given you a list of those in the end of this section of those references. The other thing you can always do is call the company. They always have drug information people who can talk to you. Now, they're somewhat bound in terms of they can only tell you what the FDA allows you to tell you, but they often will give you a guide if you're just stuck and you can't get it any other way. Okay. I always talk ahead of my... Medication safety. If you work in hospitals or big clinic groups, you're going to hear about medication safety all the time because the government is all over it. And so lots of large organizations on the OU Health Science Center campus, we had a whole group that was just dedicated to medication safety. And so they went around and inspected the clinics, they did policy writings and education of staff. So medication safety is a big thing. For kids, it's higher risk than you'll see with adults. Some of it is prescribing and transcribing errors. So you always have to look at what you've written. That's why there's other people that will look at it. A pharmacist will look at it, maybe your preceptors, nurses will also do that. So transcription errors, usually it's the unit of measure. So anytime something has to be converted, there's always the potential for something to go wrong, an error. So always going back and checking yourself for those would be important. So micrograms versus milligrams, that's a common one. Grams versus milligrams. People transpose them a lot. If you're having to convert milligram dose into a volume, like a milliliters, that's another place where people often mess up. Decimal errors. So these can result in tenfold. So those decimal errors in kids is what led to the policies now that are listed down there. Not using a leading zero. Okay? So using a zero to hold a place, the ones place versus then, yeah. So not using that can then make that a 1, okay? And then we've also talked about trailing zeros. Do we use them? No, because the same thing, that can be converted to 10. So those errors are what led to those policies in place. Doses not rounded to the nearest whole number. So it is very common at your point to calculate things to the 100th decimal point. We never do that. You have to think about what is practical for the parent of a child, or if they're an adolescent and they're giving their own medicines, what's practical. Also, how practically can you measure it? I can tell you some things, but in some of it you'll just in practice. If we're using a liquid, we only have so much accuracy we can get to. If we use those syringes, we might get to the 1/2 ml, but beyond that, the device you're using won't be totally accurate. So we're usually going to round to a reasonable amount. If you can get it to a whole number and not cause the child to be toxic, that would be good. Incorrect strength of a medication selected. So we'll see this with like Tylenol, ibuprofen. They have very concentrated forms. If you calculate the dose based on the more dilute form and then give the higher strength or the more concentrated strength, then errors can occur. Errors in administration. Now this may not be something you are, but it may be based on what you have communicated to the patient. Could be done by someone else. Could be done by a nurse in the hospital, or a therapist or respiratory therapist, or it can be the patient, the mother or father themselves, or the caregiver of the patient. So because the child is very dependent on everybody doing their job exactly right, that's where the errors come in. Most common are dosing errors, so individualizing weight-based dosing, again, you got to have a correct dose. Weight, sorry. So however you weigh them, techniques can differ by a few ounces. That may make a difference in a neonate, not so much in a 6-month-old. Increased calculation errors, okay, the conversion of pounds to kilograms we talked about. Calculation of a daily dose. You really have to watch those weight-based, because sometimes they'll tell you dose per, the milligram per dose, and sometimes they tell you milligrams per, or I'm just using milligrams, per day. Okay. Ibuprofen and Tylenol are really bad about doing that. Tylenol tells you how many doses in a day. They give you milligram per kilo per dose, and they tell you max 5 doses per day. And then ibuprofen gives you max dose per day in milligrams per kilogram. So it's really confusing. So in those, you really have to make sure your patients understand, your parents. Those two companies are really good at information that you can give to patients. You can download them. I told you about them in the first module, but you can get those and use them in your communications with patients that they can take home. Yeah, division of daily dose into multiple dose. So if you've got a daily dose, you've got to convert it into BID or TID. Conversion of milligrams to mils. So the reason to know these is to check yourself, catch yourself, so that you won't make those errors. Under selection and alteration of dosage forms, never, ever, ever, ever alter a dosage form unless you know you have not caused problems with the integrity of that dose. You will see people out there do it all the time. I'm telling you, don't do it until you check. So you can check with the company, they'll tell you. You can check, another good place is a compounding pharmacy. There aren't that many around, but there are when they are usually known within an area. So asking them, they will have good information for you. Diluting IV products, concentrated products. I'll tell you where I see the biggest problem is children that are admitted to a primarily adult hospital. Pediatric hospitals usually have lots of checks and balances in their system because of this. They also buy products that are appropriate for pediatric. In an adult hospital, very different. We'll buy a different product and we'll dilute it down, or we'll use drugs that have different preservatives in it that we don't want to use in an infant. So that's where I see problems. So maybe a small hospital, community hospital that's having to take care of all needs, the errors there might be greater because of the products that they have to buy. Under familiarity with concentrations, I would say with kids, always go for the lowest volume that you have to give them. It is hard, under age of 10, it's hard to get kids to swallow pills and tablets. Usually by the time they hit 10, they can coordinate swallowing and taking down a pill that they're not going to chew up. But before that, you're going to rely on liquids. So the least amount, because they don't always taste good. Some of you have recalled those memories from childhood and go, that was really bad. Okay, so and we've got some tricks that we can use to help make it more palatable. Always assure that the calculations for the dose are based on the correct concentration. So if you've used a certain concentration, you'll see that as we go through today, but then you choose a dosage form that has a different concentration, you'll underdose or overdose them. Always ask somebody to check your work. A nurse can check on another PA, somebody that is familiar, a pharmacist will always help you. If they don't call me in, I'll call them and yell at them. Obese children are a problem in terms of how to dose them. So I think there's more and more guidelines and recommendations coming out, but that is where you probably need to consult folks who are dealing with that area more often. I know my handout's a little bit out of sync of yours, but the medication administration concerns, think volume when you have to inject something. So little children and infants, the amount that you can put in their little muscles is limited. With adults, we can go up to 5 mLs. That doesn't sound very much, but you look at a syringe coming at you that has that much volume. It looks like a lot. For kids, I think it's a half a mil per IM. For adults, we can go up to 5. If we have to give it IV, if we have to give it very dilute, then we can give the child too much volume. Okay? But if we don't dilute it down, it may be too caustic for them to take in. So again, that's where your pharmacy is going to be a big help to you. Tablets and capsules, don't crush them, don't chew them, don't sprinkle them out unless you know the product is intended for that. And a lot of the ones that are intended for pediatrics, you can do that. You can put it over food, sprinkle it out over food. The biggest thing is you don't want them to chew it up when they do that. They probably only do it once because a lot of the drugs are bitter. The other is how much food you put it over, because if you put it over too much and they don't eat it, then they didn't get the dose. You see? It's hard. Kids are hard. I should say they're challenging. This says the average child will not be able to swallow a tablet until 6. So somewhere in that 6 to 10 is a transition time. Orals. Okay. Okay, so I showed you this picture early on. So measuring a spoon is not a spoon is not a spoon. It is different. It will measure out different amounts, which is why we never recommend they use a spoon out of their utensil drawer. Okay? Also measuring spoons, they also differ enough for a young child that you could give them too much or underdose them. Those little bulb syringes are notorious unless they have a marking and they're calibrated exactly for that. So like Nystatin is calibrated for the drug itself. It's best to use those oral syringes. Okay? And you'll see that one is, I can't read it from here, let's see. Well, they've got it divided up pretty good. They've got by teaspoon, which is good, or they've got them in mils. You got to know your patient population. I'll tell you, in Oklahoma, our ability to do math sucks. People cannot do fractions. Most dosing errors I saw in insulin were just from the fact that people couldn't do math. So you've got to work with the parent population that you have and ensure that they can do what you're asking them to do. So I like that syringe because it marks it in teaspoons, which most people understand, or it marks it in mils, which some people, it's an enigma. And then it does divide it down a little bit more. It looks like they've got it down to the 10th. Usually you don't need it to that degree of accuracy. Medicine cups that come with it, they are notorious. Depends on how you look at it. You got to look at the meniscus, which is the lowest amount on the line. But if you look at it above or below, like where you're standing and your eyeballs land, it'll dose them differently. Diphenhydramine comes with a medicine cup. For very little kids, like a 3-year-old, you can give them too much. Right doses that are easily measured by a parent. Palatability affects adherence. We talked about that. So these are devices that help drug administration, so that nutty bottle could be used with an infant. Those little sippy cup looking devices could also be used with younger children. We talked about flavoring that pharmacists can do to oral products that taste bad, or the chocolate chasers. So some people give on before and after, just in order to coat the tongue. The colder it is, usually that helps as well. Okay. Here are the resources. These are the big 4 or 5 in pediatric. So there's a pediatric injectable drugs. It wouldn't be one that I would expect you to have, but every pediatric pharmacy will, hospital pharmacy will have those. That book is golden. The pediatric and neonatal dosage handbook is the Bible in terms of dosing. And they come out they update that about I would say every 2 years. There's one also, the Red Book is another classic in terms of pediatric dosing, and then the Neofax is for dosing neonates. Another group to always look at is the American Academy of Pediatrics, AAP. They put out lots of information all the time about dosing in all things children. The guidelines that come out for pediatrics, that's the group to look at. If that's a group you're having to pay attention to, either you're rural and you're dealing with kids and you're the only thing close to a pediatrician in that area, or if you're dealing in a big city practice, these are the ones to have. So I always teach my pharmacy students, anytime you give a drug to a person, you got to have the right patient first, right? So if you're writing a order, it's busy, 5 nurses are coming at you, phone is ringing, you've got a stack of charts in front of you. I'm telling you, the distractions are huge. And the things that come at you are numerous, especially in a clinic and even in a hospital practice. So you got to make sure right patient. Right drug, you've chosen the right drug. Lots of drugs sound the same, so always having that check. Right dose for the patient, the right way it should be given, and then it's given at the right time, 5 hours. So when you write a pediatric prescription, always include the weight. One is that so whoever is looking at it can check you and know how did you get to that dose, especially if it's a dose that they don't see come across very often. So pharmacists get very used to certain ways that drugs are written. When they come across them with something different, it should catch their eye, and it should make them pause and then look. Okay. So always include the weight. Write the dose in milligram and mils. We've done that. If you're going to give 7 mLs, you write in parentheses 350 milligrams. It's a check. It's a check for whoever's having to dispense it. I always have you write the intended dose in milligrams per kilogram, because I think it's another check. Here's how I got to this dose. Select a dose that the parent and the caregiver can easily measure. So unless it's a drug that has a really narrow margin of safety, we're usually not going to give 3.25 milliliters of a drug. We won't. We'll round it to 3, or we'll round it up to 3.5 if that will work. Use your leading zeros. Don't use trailing zeros. Don't use abbreviations that are not standard. Okay. You will get very used to wherever you are where people use local abbreviations. You go somewhere else in the country and people are going to go, what is this? When I moved here from Texas, Oklahoma had its own lexicon about how they like to write prescriptions or like to write orders. And then when I would call the nurse, I couldn't understand her. Truly, I just couldn't pick up on the Oklahoma accent for a while. I was used to, Texas was in my ear and I couldn't hear it. So, that doesn't mean anything, but use standard abbreviations. Questions about those? Okay. All right, so what we're going to do next is we're going to go through each of these drugs and we're going to, on some of them, do some calculations. So the first one, you've got to know amoxicillin clavulanic acid. If you don't remember any drug before you walk into a pediatric practice, please know this one. If you don't, then don't tell them you know me. Okay? I don't know why I don't know that. Okay, so amoxicillin clavulanic acid. Remember, the clavulanic acid is there to do what? Decrease resistance. So it helps decrease the ability of the bug to break down that amoxicillin. What kind of drug is amoxicillin? What class? It's a penicillin. It's beta-lactamase penicillin. Okay. So the dose is based on the amoxicillin component. So if you see 90 milligrams per day, or per kilo per day, it's the amoxicillin. We don't care about the clavulanic acid when we're dosing. They are put together in standard formulations. You don't have to worry about it in terms of dosing. So there's a high dose and a medium or low dose, standard dose they call it. So the high dose, otitis media, which you will see till you're sick of it, community-acquired pneumonia. Those are the high dose, 90 milligrams per kilo per day. Standard dose for UTIs, 45 milligrams per kilo per day. Why are they different? Why would we have to use that high dose in some circumstances and the standard dose in others?
Isn't amoxicillin filtered out through the kidneys, so it should concentrate?
So it'll concentrate in the urine, so we can give a lower dose. But why are the other ones require a higher dose? So some of it goes to the seriousness of the infection. What else?
Resistance. High resistance.
Probably resistance, not so much. What else?
Like first pass?
Where it has to get. So drugs can get into some areas very well, but the penetration of a drug into an area determines a lot about the dose. Sometimes you just have to have high doses to drive a drug. Okay? So that's why the difference. All right, so we have a 6-month-old who is 17.5 pounds. They're actually not that tall. They're 52 centimeters. I just put it there just so you kind of start to get used to that. How do you convert inches into centimeters? 2.5 centimeters equals an inch. 2.54. Okay, so they've got an acute otitis media. The dose is 90 milligrams per kilo per day, divided every 12 hours. That's what you read in your little book if you had to, but you know that, so you don't have to look it up, right? Okay, so there's lots of dosage forms. So there are dosage forms of 125 per 5. There's 250 per 5. There are tablets. And there's an 875, there's a 500, and there's a 400. Okay, so lots of different forms. So some of this you can look up on your phone, and you can find it. The more you write in pediatrics, the more you'll have a form that you want to use. So knowing the age of the child will determine whether you're going to use a liquid or a tablet. And we're always trying to go for the lowest volume, or the least amount of tablets, or the least number of times that we have to give it in a day, okay? All right. So, there are other suspensions available as well. I think I put them all down there. So the 125, the 200, the 400, and the 600. All right? So you've got all that information in your handout. So I want you to calculate that. So calculate it, how would you write that order? So calculate it and write out how much you would need to give the person for the length of time you decided. This one you should be easy peasy for you guys. Everybody got it? Still working on it? Everybody got it? Okay, what's the first thing you have to do? Okay, weight, so how much they weigh? 17 pounds. The biggest thing I would encourage you to do if you have trouble math-wise is keep your units going. Units will always tell you where you are and what to do, usually. So you got 2.2 kilos per pound, right? And you said that came out to what? 8? Okay. What's the next thing you do? So what's your dose? 8? You said you got 8 kilogram kid and you're going to use what? 90 milligrams per kilo. Is it per day or dose? Per day. Okay, so that's one thing to keep in mind. So you get 720. So 720 milligrams per day. Okay. At this point, I would suggest splitting it into what you're going to do. That's why you won't mess up if you're. So how much are you going to? How often are you going to give it? Every 12. Every 12. So what's that convert to? 360 milligrams per dose. And how often? Every 12. Every 12. Okay. Now you have to choose what kind of strength. You can't mess up if you're going to use a liquid, right, because you've got an infant. So you can use any of them. It goes to volume. So which volume, which concentration are you going to use? Okay, let's the 600 is 600 per 5.
Yeah.
How do I get from there to there?
360 times 5 over 600.
So if you've got 600 milligrams, this ratio is your friend, and you've got 360 in X. Everybody remember how to do that? Okay, so then you cross multiply, right? So 360 times 5 divided by 6 gives you how many mils? 3 mils. So you're going to use 3 mils every 12 hours, right? So you're going to write it 3 mils, 60 milligrams, q12 hours. So how much are you going to write to dispense? How many days worth are you going to give them? How many? 10 days for otitis. Okay. So now you got to go back. This is how many in a day? It's 6 mils per day times 10 is going to give you 60 milliliters. If you will write it that far, the pharmacist is going to determine what kind of volume to give them. Because these come standard. Okay, everybody follow that? Okay, that's our easiest one. So if you do that, that's good. If you can't, you need to come see me. Okay, next page. The cephalosporins. These are really common. So Keflex is first generation cephalosporin. Very good for soft skin tissue, soft tissue, and skin infections. So anything on the skin, it's also actually pretty good with UTIs too because it concentrates in the urine. So you need to know that dose, 25 to 50 milligrams per kilo per day every 6 hours. Keflex is kind of easy because the first generations you just have to dose frequent. That makes it a little bit of a drawback. And there's lots of forms, just like you see with the penicillins. So commit that one to memory. Ceftamir, Omnicef, third generation. So a third generation cephalosporin tells you what? What's going to be the difference between it and Keflex? Gram negatives. So your gram positives, so the first generation is going to cover what? Staph, strep, so those are good for skin, right? Makes sense, remembering? Okay, so Omnicef is kind of the go-to oral, especially for kids. And it's going to be for probably more severe or significant infection. So you see there, you can give it for otitis, you can give it for bacterial pneumonia, kids with penicillin non-type 1 allergy. What are those kids? What's a non-type 1? Are they going to give you anaphylactics? No. So what are they going to have? Urticaria, rash. Okay. So this one, again, you commit to memory, 14 milligrams per kilo per day, 1 to 2 times a day. What's the one thing you want to tell somebody when you give them a Septanir prescription? Their poop turns red. Maximum dose, is this one on your max dose? 600 milligrams is your max per day. So these are your 2 go-tos. First generation, you've got a mostly gram-positive you're worried about, Keflex. You've got, you need a broader spectrum Septanir. Sulfonamides, another one of your big friends, but the problem is resistance is going up with them. Still a fairly useful drug in most situations. Look at that ratio, 5 to 1, always set for you. You do not have to worry about that, but we dose it based on trimethoprim. So when they give you that milligram per kilo per day, they're telling you the trimethoprim dose or component. Okay? You must know that maximum of the trimethoprim 160 per dose. Very, very common drug. Okay, so let's do the calculations on it. Okay, so you have a 3-year-old female. She is 38.8, well, I'm giving you the kilos up there, 94 centimeters. She's got a UTI. You have trimethoprim sulfamethoxazole 240 in 5 ml. Determine the dose for 3 days. The dose and the amount that you're going to write for in 3 days. And we'll take a break after this. Everybody got it? Anybody not? Want more time? Okay, what's the first thing you have to do? How much did they weigh?
14 kilograms.
Okay, so this one I gave you 14 kilos, and what's the dose?
8.
8 what?
Milligrams per kg.
Is it per dose or per day?
Per day. It doesn't have kilograms. It doesn't have
Yeah,
stuff.
8 milligrams per day.
So what's that calculate to be?
He doesn't have kilograms on our paper. It just says recommended dose of 8 milligrams TMP per day.
Look up above in the under sulfonamides, 6 to 12 trimethoprim per kilo per day. I've given you the 8 so you don't have to decide. Okay, so what's that calculate to? 112 milligrams per day, right? Okay. So in how often are we going to give it? Q12. So what's that going to be per dose? 56 milligrams. I'm telling you, keep your units with you per dose. Okay. So what is our strength of our product? You don't care about the 200, do we? So 40 milligrams in how much volume? 5 mLs. Okay, and we've got 56 milligrams, and we want to know in X. So you cross multiply, and what do you get?
56.
You get 7, right? 7 mLs. Please calculate 7 mLs. So how much are you going to give them for the doses that you? 42 mils. Okay, everybody follow that? If you are having problems with this and do not understand how that's, I'm getting these, come see me. Okay. I'll be out the rest of this week, but I'll be in all next week. Okay, let's take a break and we'll come back.